Our next speaker is Allison Berg, once again from the Allina Health and Minneapolis Heart Institute. Allison is a board-certified licensed genetic counselor with Allina Health, where she has been helping patients and families since 2017 with deep expertise in hereditary heart conditions, including aortopathies. Did I say that? Aortopathies, okay, sorry. Cardiomyopathies, arrhythmia, and connective tissue disorders. You're really challenging my vocabulary today. It just goes to show you if I paid attention to with my cardiologist. Allison plays a vital role in helping people understand how genetics can impact their heart health. Her patient-centered approach makes complex genetic information approachable and empowering. She helps families recognize risks, ask the right questions, make informed decisions that can truly be life-saving. So please welcome Allison Berg.
Thank you for having me today. This is something I'm very passionate about. So I am going to talk about genetics and the aorta today. A few things I really want to go over, and I don't know which TV to look at. There are so many. But I want to first review basics of genetics. A lot of us probably haven't had a genetics lesson since maybe high school or if you took any college courses. So we'll just go through basic genetic ideas so we're all on the same page. And then we'll talk about when is genetic testing or counseling maybe right for somebody. So we'll kind of walk through what we look for in patients that might give us an idea that they should consider genetic counseling or testing. And we'll discuss the importance of family history, and I love that it's been brought up by some of the other speakers today because it really is important if you know your family history. So we'll talk about key things that I look for when I'm taking a family history on an individual. And then I hope that we can understand the process of genetic testing, the process, the logistics. That's the actually real easy part with genetic testing, so we'll kind of walk through that. Benefits and limitations, there's good and bad. And so I always want patients to be aware of both. When I'm talking with them about the option of genetic testing, I want them to know what are some good things that can come from it, but what are the limitations? Genetics isn't perfect, so we need to go over those as well. And then we'll talk about inheritance. How are these genetic causes of aneurysm and dissection typically inherited in families? So who else is at risk? If I've had an aneurysm or dissection, who else in my family should be concerned and what should they be doing? So those are the kind of things I want to address with you all today. Maybe. It's not working here. Okay. So first I wanted to talk about what is a genetic counselor. Oftentimes when I meet someone for the first time, the question always comes up, well, what do you do? I sometimes just will say I'm in healthcare because if I say genetic counselor, many times I get this blank look and people are like, oh, neat. So I just want to educate people. If you haven't seen a genetic counselor or talked to a genetic counselor before, I actually really liked the AI definition of genetic counselor. It kind of encompassed everything that I thought we did. And so a genetic counselor is a medical professional, who helps individuals and families understand genetic conditions, assess their risk for inherited diseases, interpret genetic test results so that the patient can understand it and share it with their family. But I think also a big part is really navigating the emotional, ethical, and other implications to really try and empower patients and families to make decisions that are right for them. Genetic testing may not be right for everybody. And so when someone maybe is recommended to have genetic testing, the first thing when I meet with them, I want them to understand it's a choice and go over with them what things might be beneficial for them, what things do they maybe see as a drawback, so that we can work together to come to a decision about whether they're going to test and then what that information means for them. So, jumping into our basic genetics review, you might recognize this picture. These are our chromosomes. So this is kind of how our genetic information is packed within our cells. And these noodle structures that we call our chromosomes, we typically have 46 of them. That's kind of the magical number that we expect to have. You can see that they come in pairs. So we typically will have 2 copies of every chromosome. That's because we get one from mom, one from dad. So we're that perfect blend of our parents because we have half of mom's chromosomes, half of dad's chromosomes to create us. Each one of these chromosomes contains hundreds of genes. And a gene is basically just a segment of our DNA that has a particular function in the body. And altogether, we think we have about 20,000 genes. When I was in school, not too long ago, we thought we had 30 to 35,000 genes. So we're actually becoming less complex than we originally thought we were. But these 46 chromosomes contain all those 20,000 genes. And because we have 2 copies of every chromosome, we have 2 copies of every gene. Again, one comes from mom, one comes from dad. Now, when we do a genetic test, we aren't looking to see if you have a gene. So a lot of times people will say, oh, my mom has the gene for this condition. We all have the genes. We all have the same set of genes. When we do genetic testing, what we're doing is we're looking for changes or what we call variations within these genes that might cause them not to work and therefore could lead to a health condition. But it is normal to have changes in our genes. That's what makes us different from one another. We all have normal variation within our genes as well. So a little bit more about the genetics background. So on the right here, if we take a look, we have the cell, the basic building block of our bodies. We have the chromosome, but if we unwind that chromosome down to the smallest unit, that's where we see our genes. And again, a gene is just a segment of our DNA that has a particular function in the body. Our genes are made of what we call base pairs. These are basically chemicals, and there's 4 of them that make up all of our DNA. We represent them by the letters A, T, C, and G. And every gene has an expected sequence of those 4 letters. So there's a typical way those letters should be in order for every gene so that it makes sense for our body. What we do when we're doing genetic testing, again, is we're looking for any variation in those letters. We're looking for spelling errors, basically, in a gene. And so genetic testing is reading those genes, looking at the combination of A's, T's, C's, and G's. And as I mentioned before, normal to have some variation from person to person, and those are what we call benign genetic changes. This is not for us to go through. This is just to show how complex genetics can be, and this is specifically looking at the genetics of the aorta. So if we're getting down to the cellular level of the aorta, all of these highlighted red letters, numbers, those are the names of genes that are important in the aorta. And they have an importance as far as keeping the cells of the aorta held together. And that's all those genes on the right. Those are the genes we know of right now that can lead to aortic aneurysms or dissections if they have a mutation. So again, I don't expect anyone to want to understand this. It just is to show you how complex and how many genes are important in the aorta. So who should see a genetic counselor, or when should genetic testing be recommended for somebody? Myself or some of the providers, if they see an individual who has a personal history of aneurysm or dissection, but they also maybe are young, maybe under the age of 60, we start to think about there could be a genetic cause. Unfortunately, as we all get older, our bodies get weaker in many different ways, and the aorta is one way it can get weaker. So with age, it can be normal for aneurysms to happen, but we look for people who have it at a younger age. The size of the aneurysm, maybe it's bigger than what we would expect for someone's age. Maybe there's not other factors present. So we know that external factors, lifestyle factors, can increase someone's risk for aneurysms. What if those things aren't present in somebody? Then we start to think about maybe genetics is playing a role. When we see a patient, we might look at them and say, you've got some other unique physical features that make us think of a syndromic cause for aneurysm or dissection. And I'm going to talk a little bit about that on the next slide. What syndromes we can see. And then if you have an aneurysm or dissection and you have a family member, we start to think maybe there's a hereditary component. And then maybe you actually have a family member who has a gene mutation that has been found to cause aneurysm and dissection. You should probably think about genetic testing for yourself. So many of you maybe have heard of this Marfan syndrome and Loeys-Dietz syndrome, but we have syndromic and non-syndromic causes of aneurysms and dissections. A syndromic cause means that the aneurysm or dissection is just part of a bigger condition. Common examples in this situation are Marfan and Loeys-Dietz. So if we see someone, they're really tall for their family background. They have really long fingers, they have really long toes, maybe they have scoliosis, they might have some different physical features. We might start to think they could have Marfan syndrome, and we would maybe encourage genetic testing for that. Loeys-Dietz is also a syndrome that you can see aneurysms and dissections. It's pretty similar to Marfan syndrome, again, tall, thin, just some of those physical features. One unique thing with Loeys-Dietz is that uvula that hangs in the back of your throat, sometimes it's what we call bifid. It looks like it's split in two. So instead of one nice teardrop, you have two teardrops. That can be an indicator of Loeys-Dietz syndrome. So that's a unique feature that we pay attention to. And then we have the non-syndromic form. So there are some genes that just increase your risk for aneurysm and dissection. We wouldn't expect to see other features associated with it. So jumping into the genetic counseling visit. So when I have a patient that's referred to me, what is that visit going to look like, and what are we going to discuss? The first thing I'm going to do is get a family history. Now, I understand that not everyone is going to know the health history of their family members, whether they just don't have a family that communicates about that type of thing, or they are adopted. Different things can lead to you not having knowledge of your family. But for the most part, I'm going to try and get a 3-generation family history. So that's going to be the patient and their siblings, their parents and aunts and uncles, and then grandparents. And I will not usually try to go back any further than that, because we usually don't know much more than that. Typical things I'm going to look for, anyone else with aneurysm or dissection? Has anybody died suddenly or unexpectedly? And this is a big one when we go back in the generations. A lot of times people say, well, I had an uncle who died at 50 from a heart attack. Well, was it a heart attack? Or did they not maybe have an autopsy, and it could have been something else. It could have been aneurysm or dissection. So a lot of times back in the generations, we didn't have the knowledge to diagnose it maybe more specifically than just saying heart attack. So I always look for those types of things. I will ask about anyone in the family with some of these syndromic features, just to see if we're dealing maybe with Marfan syndrome. And then ancestry can be important. So there are certain genetic conditions that are more common in certain populations. So I'll add, I want to know, are you German? Are you French Canadian, Hispanic, Ashkenazi Jewish? Those types of things can be important when it comes to thinking about genetic conditions. So then after we get through the family history, we'll review that together. We'll move into what's the good and bad of genetic testing. So from my perspective, some of the benefits can be that we can maybe confirm a hereditary or genetic cause. This can be a benefit. I think it can also be a limitation depending on how somebody looks at it. But from what I can see, if we confirm that someone has a genetic diagnosis, it can help their providers best take care of them and manage them based on what the genetic diagnosis might be. It may alter medical management. So people who have a genetic cause, it may lower the threshold for when they want to consider surgical intervention. So we typically don't want an aneurysm to get as big if you have a genetic cause, so they will consider surgical intervention sooner rather than later. If we find a genetic cause, then family members have the option to learn if they are at risk, and they can do things to proactively manage or screen for the possibility of an aneurysm or dissection. It may explain a family history. So maybe there's been a long family history of aneurysms, dissections, sudden death. And I've had a lot of people who say, oh yeah, it's the Smith family curse or something, that no one lives beyond 50 or 60. Well, maybe we just found out it's not a curse, it's actually genetic hereditary. It could explain that history. I think our overall goal, and really the goal of all of this, is to reduce the likelihood of a sudden event. And if we can identify people who are at risk by genetics, that's our hope, is that we can reduce that chance. The cost of testing, I did put that on the benefit side. Some people might argue, but genetic testing is becoming more affordable. We used to think genetic testing, oh my gosh, it's going to be thousands of dollars. It's not that way anymore. A lot of labs are competing with one another to bring prices down. So many patients pay nothing out of pocket or a few $100s depending on maybe a deductible or copay. And then some of the limitations. So one thing I always want people to know when I meet with them about genetic testing or genetics in general is that we don't know everything yet. Genetics is an area of medicine that's really young. When I came out of school, there were maybe only just a couple genes that we could test for aneurysm and dissection, and now there's almost 30 plus. So it really is something that's changing all the time. We're finding new genes all the time that can cause aortic aneurysm or dissection. But right now, I always want people to know we don't know all the genes yet. And that leads into the fact that if we don't find anything on someone's genetic test, that can be reassuring for family members, but that does not eliminate the possibility of something genetic. So if we don't find anything on the genetic testing, I always want people to understand your family members should probably still at least consider having an echo or some type of screening of the aorta, because there still may be a risk. Maybe it's a gene we haven't identified yet. So just very cautious when we don't get a result or a positive result. There is such thing as an uncertain genetic test result. It happens actually more than I like, and that can be confusing for families, for patients. So the uncertainty that can come from that can be complicated. I always try my best to explain it to patients and to families, but it can still be a little bit confusing. And then this is a big one that I try to explore with patients before they do genetic testing, is that sometimes we can feel a sense of guilt. So of course we have no control over our genetics, but if we identify a gene mutation in ourselves, I think if you have children, you think, I might have passed this on to them now. And you have that sense of guilt. I think any parent would have that sense of guilt. Again, we have no control over our genetics, but I've heard this time and time again about that guilt. So I do like to explore that with people before they do genetic testing so that they may prepare for some of those types of feelings. The process, like I said, it's pretty straightforward. In my practice, I just do a cheek swab. I mean, you can get a sample, cheek, spit, blood, however you like. I just do cheek swab because it's super simple. I can mail kits to patients' houses. They don't have to come in to see me in person. We can do virtual visits. And then once we get the sample, we will ship that off to the laboratory. The laboratory is just gonna look at the genes that we are interested in. So we are only going to look at genes that can cause aneurysm or dissection. We are not going exploring. We're not going to learn ancestry. We're not going to learn like cancer risks. I always want people to know this is focused testing. It's also not like the 23andMe or Ancestry.com. You're not going to find long lost relatives. You're not going to be out there in some huge database. This is clinical diagnostic testing that is private and de-identified. And then once the lab looks at those genes, again, looking for mistakes in the genes, they will send a report to the provider or me, and I will call out the patient. So regardless of the result, I always call it out. And my goal is to try and explain what the result is. What does it mean for the patient, and what does it mean for their family? There's 3 results of genetic testing. The first one is negative. This means that all the genes looked great. There was nothing that was picked up in those 29 genes. This, again, it reduces the likelihood of a genetic cause. It does not eliminate that possibility completely, as I mentioned, because there are still genes out there that exist and we haven't found them yet. We do recommend, again, that first degree relatives, so that would be siblings, children, parents, at least consider imaging as kind of a baseline. We can consider genetic testing again. If someone has a negative test result, we can test again in a few years, because as time goes on, we're going to find more genes. Testing is going to get better, so we can always consider testing again later on to try again and see if we find anything different. That uncertain result I briefly mentioned, this is where the laboratory, they may find a little difference in a gene. but maybe that particular difference just hasn't been seen very often before. So they don't know, does this cause the gene not to work and therefore lead to a risk for aneurysm or dissection, or is this one of those normal benign genetic changes that people can have? Sometimes they don't know because, again, we're still in a process of learning. I do not recommend testing any family members for an uncertain result because we would not know what that would mean for that individual. I almost treat these like a negative result. We typically do not want to take any action on uncertainty. Occasionally in some families, if there's a family history of aneurysm and dissection, we can then kind of go tracking this uncertain gene. So we might recommend testing those affected family members for the gene change to see, does everyone in the family who has aneurysm or dissection also share this uncertain change? That might be enough to say, yep, in this family, this gene is a problem. And that might give us an answer for that particular family. And then finally, we have a positive result. Again, this is diagnostic. It confirms why a person had their event. It can help guide the management, again, with surgery. They may be recommended, you know what, no contact sports, no strenuous activity. We want to maybe reduce the likelihood of any significant events. This does allow for family member testing. So when we find a gene mutation in a person, we can then offer testing to any family member. And most of the labs offer it at no charge. So at the lab I use, if we find a gene mutation, any family member can have free genetic testing for that specific gene mutation. And so we try to offer as much as we can to anyone who is interested. And then there is the potential for gene therapy. So gene therapy, there are trials right now in cardiovascular genetics, not specific to the aorta yet. I'm hoping we'll get there. And so I think that genetic testing will be really beneficial in treatment eventually. So that's my hope. I think it's definitely coming. I did just want to quickly go over the inheritance. Most genetic causes of aneurysm or dissection are inherited in what's called an autosomal dominant manner. Autosomal means both men and women can be affected, so this does not pick a gender. Dominant means only one copy of the gene has to be mutated in order to have the condition. So if you think about it, again, we all have 2 copies of every gene. One copy has a mutation, that's enough to put you at risk for aneurysm or dissection. Whereas there are some conditions, and I know they mentioned cystic fibrosis, where you have to have 2 mutations in order to have the condition. So with autosomal dominant, you have 1 mutation. When you go to have a child, you're passing down 1 copy of every gene. You're either going to pass down that normal copy or that mutated copy. So there's a 50% inheritance risk for any family member, or for first-degree relatives of someone with a gene mutation. And then finally, I just wanted to go over a quick case example. This was a patient right there who I saw. She was in her early 50s, and she came to me because she had a coronary artery dissection, so not an aortic dissection, but a smaller vessel, and she was diagnosed with fibromuscular dysplasia. And this fibromuscular dysplasia does cause aneurysms or dissections in the smaller vessels, but we don't typically think of problems with the aorta. When I took her family history, which she has a really big family, you can see she's got 3 children here in their 20s, all pretty healthy. She had a brother, unfortunately, who passed away at 46 from alcoholism. Her dad's side of the family, not a whole lot, just kind of typical things going on his side. But then we see mom's side. She has many siblings. But we do see that she has a sister, or the patient has an aunt who's 94. She had a ruptured aneurysm. That aunt has a grandchild who unfortunately passed away in his 30s from a ruptured aneurysm. That is going to raise some red flags. That is going to make us think there might be something going on here. And then if you look all the way down at the end, there was also my patient had a cousin with another ruptured aorta. So I asked the patient, I said, you know, I'm really concerned. Do you think you can reach out to those family members and see if they've ever had genetic testing? With such a history, you would think someone did genetic testing. And sure enough, she learned that this aunt and the aunt's grandchild were found to have a mutation causing Loeys-Dietz. And so her mom was then tested and also had the gene mutation. So we now know that my patient was at a 50% chance to also have the Loeys-Dietz mutation and be at risk for potential aortic aneurysm and dissection and maybe some other features with Loeys-Dietz. So we tested her. She was positive. We tested some of her children. Some of them are positive. So it changed how these family members were screened. And it really just highlights the importance of maybe trying to learn a little bit about your family history and see, has anyone else in the family had genetic testing? Because that can be really helpful for the patient and their care. So hopefully, just key takeaways, genetic testing can help diagnose and provide a more personalized treatment plan. We can provide accurate risk assessment for family members. Family members hopefully can reduce the risk of sudden, potentially catastrophic events, and then future possibilities of gene therapies. I did want to just let you know that if anyone you know, family, friends, ever wants to consider genetic testing, there's nsgc.org, which is our national organization. You can go on there, and there's a Find a Genetic Counselor tab, and you can find a genetic counselor in any area, whether it's cardiology, prenatal, cancer, and you just type in your location and your interest, and then they'll get you set up with someone who is near you. And I appreciate your time, so thank you very much. Thanks. Yeah, thank you.
I want to thank everyone for attending today. Thank you to, obviously, all the providers and speakers that were here today. Thank you for attending. Thank you for all the great people and partnerships that we've made over the years that has helped make this possible.